Lipshutz from UCLA. The topic of his talk is mRNA 3927 therapy for Propionic acidemia, interim data from a phase 1/2 study.
Thank you. I'd like to thank the organizers for allowing me to present this data on behalf of the study principal site investigators. So this is the disclosure of the authors are listed here. The study was funded by Moderna, and a plain language summary can be accessed by scanning the QR code that you see on the screen there. Propionic acidemia is a rare and severe inherited metabolic disorder. It is caused by pathogenic variants in PCCA or PCCB genes, leading to a deficiency of the mitochondrial propionyl-CoA carboxylase enzyme, also known as PCC. In PA, deficient PCC enzyme activity results in a block in the propionate pathway and is associated with accumulation of toxic metabolites. PA is primarily a pediatric disease with onset typically in neonates and is characterized by recurrent life-threatening metabolic decompensation events, also known as MDEs, and multisystemic complications resulting in significant morbidity and mortality. Importantly, long-term cognitive outcome is negative correlated with the number of MDEs. There are many multisystemic complications of PA listed on the right side of the screen. There are no approved therapies to treat the underlying enzyme defect of PA. Current management of patients primarily focuses on medical nutrition therapy to reduce toxic metabolite accumulation by strict restriction of dietary sources of propiogenic amino acids. mRNA 3927 is a novel, intravenously administered lipid nanoparticle encapsulated dual mRNA therapy that encodes both PCCA and PCCB subunit proteins to restore functional PCC enzyme activity in the liver. By restoring intracellular proteins, mRNA therapy has a potential role in preventing acute metabolic decompensations in patients with PA. This presentation reports the interim results of a global phase 1, phase 2 clinical trial, open-label dose optimization study to evaluate the safety, pharmacodynamics, and pharmacokinetics of mRNA 3927 in participants with propionic acidemia. The study is a 3+3 dose escalation design. Dose-limiting toxicities, or DLTs, were defined as adverse events that occurred during the first 14 days following administration of the first dose of mRNA 3927, were at least grade 3 in severity and were regarded as possibly or probably related to mRNA 3927. If a dose-limiting toxicity occurred, an additional 3 patients were to be enrolled to further characterize the safety and tolerability at that dose. The primary objective of the study is to evaluate the safety and tolerability of mRNA 3927 in patients with PA as evaluated by the incidence and severity of adverse events, serious adverse events, and adverse events leading to treatment discontinuation. Secondary endpoints include pharmacokinetics and pharmacodynamics of mRNA 3927. The clinical effect of mRNA 3927, including its effect on metabolic decompensation events, is an exploratory objective. Participants receive up to 10 doses of mRNA 3927 and then may enter a 2-year safety follow-up period or may continue to receive mRNA 3927 as part of an extension study. The study enrolled children and adults with a confirmed diagnosis of PA based on molecular genetic testing, aged 1 year or older at the time of consent. The first 2 patients to receive mRNA 3927 in the first dosing cohort were to be 8 years of age or over. Participants were enrolled in the US, Canada, and the UK. Exclusion criteria are listed on the right-hand side of the slide, but most importantly, a history of transplant, hypersensitivity to components of mRNA 3927, or a GFR less than 30, below 30 were excluded. This is the patient disposition as of March 31st of this year. 16 patients had received intravenous mRNA 3927 doses across 5 cohorts. You can see the first cohort was 0.3 milligrams per kilogram every 3 weeks, and the subsequent cohorts received either 0.3, 0.45, 0.6, or 0.9 milligrams per kilograms every 2 weeks. As per the protocol, an additional patient was enrolled in cohort 1 after one patient in this cohort discontinued the study after their first dose. In total, 2 patients had discontinued from the trial. All patients have completed the P101 study. All of the patients who completed the P101 study have elected to enroll in the extension study to continue to receive the study drug. Across both studies, more than 280 doses of mRNA 3927 have been administered, resulting in 13.2 patient years of overall exposure to mRNA 3927 across all 5 cohorts. 5 patients have more than 1 year of dosing. These are the patient demographics and baseline characteristics. There's 16 patients with an equal distribution of males and females across the 5 cohorts. The age at the time of enrollment was from 1.3 years to 26.8 years. Disease onset was defined as the first MDE, which in most cases occurred shortly following birth. Of the 16 patients, 7 are white, 5 are Asian, and 2 are Black or African American. 8 patients have variants of PCC-A gene and 8 have variants of PCC-B. This slide shows the most common treatment-emergent adverse events, also known as TEAEs, defined by cohort. TEAEs are defined as any adverse event reported on or after the date of the intervention, when the intervention began, regardless of whether or not they were considered related to the study drug. Because data are presented for the P101 study and the extension trial combined, the overall duration of exposure to the different dosing regimen varies and is shorter in the most recent cohorts. TEAEs occurring in more than 2 patients overall are shown in the slide. All may be related to the disease or the patient's underlying susceptibility to infection. As of March 31st of this year, there were no dose-limiting toxicities. Of the 16 patients enrolled, TEAEs were reported in 15 overall. Drug-related TEAEs occurred in 9. Serious adverse events were reported in 8 patients. Most of these events, 31 of the 54 reported, were considered related to the underlying disease, propionic acidemia. 2 of the 16 patients reported a total of 3 drug-related serious adverse events. 1 patient had a grade 3 event as pancreatitis, and another had a vascular device infection and injection site reaction, both considered grade 2, consistent with infusion site reactions in that 1 patient. Infusion-related reactions, or IRRs, were defined by a temporal relationship to drug administration. Any drug-related adverse event that occurred within 24 hours of the start of a dose was considered an IRR. IRRs occurred in 6 patients and in 19 of the 288 doses given, or 6.6%. All IRRs were grade 1 or 2 in severity. Most occurred in cohort 1. The pharmacy manual was revised after cohort 1 to decrease the rate of infusion, which resulted in fewer IRRs in the subsequent cohorts. 2 patients had IRRs with 1 dose. 3 patients with 2 of their doses, and 1 patient in cohort 1 had IRRs with 11 of their 39 doses that they received. 3 hypersensitivity reactions occurred in 1 patient that consisted of rashes. This slide shows a timeline of the metabolic decompensation events for each patient 12 months before and following mRNA 3927 treatment initiation. Each gray horizontal line represents an individual patient, and the brackets on the left-hand side represent each cohort. Dark red circles represent the MDEs that occurred within approximately 1 year pre-treatment retrospective observation period, or during the 2-week dosing interval after treatment. The pink circles represent MDEs that occurred outside of the 2-week dosing interval. The triangles represent the point of latest follow-up. 8 of 16 patients had MDEs in the in the pretreatment observation period, 2 in cohort 1, 2 in cohort 2, 3 in cohort 3, and 1 in cohort 5. In cohort 3, which was the 0.45 milligram per kilogram dose every 2 weeks, all 3 patients had at least 1 MDE, which was 2 to 4 episodes during the pretreatment period of approximately 1 year, and no MDEs after receiving treatment with mRNA 3927 over a period of 8 to 10 months. Overall, in patients with at least 1 MDE in the pretreatment period, the reduction in annualized MDE frequency was 66% compared to the 1-year pretreatment retrospective period. If we exclude cohort 1, which was the dosing every 3 weeks, rather than every 2 weeks of the other dosing cohorts, the annualized MDE frequency was the reduction in annualized frequency of MDEs was reduced 78% compared to the 1-year pretreatment retrospective period. Here are the conclusions. First, this is the first clinical trial reporting results of an mRNA therapeutic for intracellular protein replacement. 16 patients have received mRNA 3927, and more than 280 intravenous doses of mRNA 3927 have been administered. 5 patients have received more than 1 year of dosing, and all eligible participants have opted to extend into the open label study. To date, mRNA 3927 has been well tolerated in patients with propionic acidemia at all the doses administered with no dose-limiting toxicities. Results show encouraging early signs of potential clinical benefit with mRNA 3927. In patients who reported MDEs in the 12 months before dosing, reduction in number of MDEs was observed after the start of treatment with mRNA 3927. This study is ongoing, and the next steps include confirming the optimal therapeutic dose and evaluating the optimal dose in additional patients, including infants. Thank you.
Now the paper is open for discussion.
Hey, Jerry. Chuck Venditti, NIH. What happened to the metabolites?
That data is still being analyzed and being collected, so we don't have that to report today.
And could you further comment on the pancreatitis in the patients? That's a potentially lethal complication in these patients. And it can be precipitated, in my experience. No one really knows. It's multifactorial, but one of the things I always get concerned about in patients is they're getting too much lipid. Can you comment on that patients with pancreatitis, that they have recurrent pancreatitis? Because some patients get it more frequently.
I don't have a number of details on that patient. I'd be happy to collect those details and discuss it with you later. But it was one patient, and there's been many, many doses administered. But I can collect more details and discuss it with you.
Thanks.
Thanks. It's really exciting to see new mRNA therapies for metabolic diseases. Sorry, Andrew Grimm, Ultragenics. I wanted to ask about the duration of the infusions. You mentioned you slow the infusions down after the first cohort. How long do the infusions take, and did you do a ramped or stepwise infusion?
The doses typically are over roughly about 4 hours. It depends on how much the patients weigh. The patient, in our patients at our center, yes, the dose rate is increased after the first doses. When they've tolerated them, we can slowly increase the dose. So a longer period of time at the beginning, and then shortening the time as the infusion proceeds. But yes, it is more ramp-like as you described.
Okay. And did you have to pre-medicate the patients at all with antihistamines or
Yes.
acetaminophen?
Antihistamines including H1, H2, and acetaminophen, yes.
Thanks.
It's great data on mRNA therapy. Can you comment on your experience on anti-drug antibody response or to any response to LNP components in repeat dosing?
Any anti-drug antibodies, and what was the other?
Any LNP component.
I don't know the answer to that question at this time. It's still being looked at whether there's been an immune response to the repeat lipid nanoparticle administration. It's not data that I have at this time to share.
About the transgene anti-drug antibody response?
To the transgene product itself, that data is still being collected, and we don't have the results at this time.
Thank you.
We have a question from the internet here. Impressive results. This is from Irani Manoli. Impressive results. Can you comment on metabolite trends in the trial? Are patients getting a central line? And how do you monitor for immune response, especially in patients with 2 nonsense mutations?
Okay, so regarding the question about, I think, access for administration, I think that it's dependent on what the patient came in with, potentially. I know that at our center, patients are getting a peripheral IV each time and having the infusion that way. I know that we've had patients ask us about central lines. If they have a central line, can it be used? So I think that's individualized by the situation, but they don't require central access to have the administration. With regards to the monitoring of 2 different mutations and responses, I don't know that I can answer that question, that I have the data to give an answer that's educated.
This probably better be last question.
Okay, yeah, last question.
I just wanted to provide additional information regarding the pancreatitis episode that happened on the patient. So this was a patient that had recurrent pancreatitis before he enrolled in the study. And the one episode of pancreatitis that occurred during the study was in fact less severe than previous episodes he'd had before enrolling in the study.
Okay. Thank you.
Thank you.